All right, thank you for having me today. Can everyone hear me all right? Good? Okay. Um, let me see, this is the clicker. Technical difficulties. So my background is in human development and family studies, which focuses on understanding why children and families develop in positive or negative ways and creating interventions to promote positive development. So that's really where my training is. And in my training, I focus most on adolescent development. It's what I do the most today also. But there was a lot of focus on childhood development and early childhood and how that plays into adolescent development. And at UNMC, I focus on maternal and child health specifically. So within that, more adolescence, but also early childhood. I teach the life course health for our maternal and child health students who are pursuing their Master of Public Health degree, and also the interventions and theories in maternal and child health class. So, I've had a lot of different experiences and I guess just different experiences teaching about adverse childhood experiences because they really play into so many different developmental outcomes, which we'll talk about today. And beyond that, I had a premature infant. So this is my son, Nathan. He was born almost 11 years ago. We're really excited that he has been very healthy. You can see this was right after he was born. He could breathe on his own. He was in the NICU for a week. And then they transferred him to our hospital nursery. Unfortunately, I had to take a little flight over to a hospital with a NICU, so he was there for a week. Then they transferred him back an hour to our hospital, and he was in the nursery for 2 weeks just so he could learn to suck, swallow, and breathe and get to the right weight and all those things. But having a premature infant, I think, has expanded my knowledge of early childhood and expanded my understanding of how ACEs, in particular, the adverse childhood experiences, could intersect with prematurity to really produce some negative outcomes. So that's what we'll talk about the most today. So have people heard of adverse childhood experiences? Sounds like some people have, some people haven't. There's a whole initiative in Omaha called Trauma-Informed Communities, and it's focused on educating more people around adverse childhood experiences. That's why I asked. Some of it focuses on the healthcare environment in particular. But I'll go, the first probably half of the presentation, I'll talk about that. Then I'll talk about the implications for premature birth and premature infants. There is a spoiler alert, though. There isn't a lot of information out there specific to preemies. So that's definitely an area for future research and something I'll talk about later. And then the relevant interventions. What can we do to promote those positive outcomes that we want to see for all children, but particularly for preemies? So the original adverse childhood experiences study was conducted in the 90s. It was a partnership between the Centers for Disease Control Prevention and Kaiser Permanente healthcare system. So all of the people who participated were adults. They were receiving care through Kaiser Permanente. And basically a survey was conducted. They were asked to describe or actually mark if they had ever experienced 10 types of trauma as a child before the age of 18. So they were reflecting back on their childhood. And they really focused on the types of trauma that were most common among the patients in their healthcare system, and also the types of trauma that had the most information from the literature. And in this study, what was really kind of groundbreaking is they linked early trauma to long-term health outcomes and a lot of different mental and physical health outcomes. So I'll talk more about that in a minute. I did want to note, this is a very busy slide, much busier than I would normally have. But I think people get caught up in what the ACEs are and how they're defined. So I wanted to list the ACEs and then have the question that they used to actually determine if a person had that particular ACE. So the ACEs that they studied were mental illness, substance abuse, incarceration, parental separation or divorce, intimate partner violence, physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect. In more recent ACE surveys, I've seen that physical neglect and emotional neglect aren't there. I'm not sure why that is, to be honest, but that's been a change in the original study they were included. I think the ones that trip people up a little bit, because there are maybe different definitions, might be physical abuse and emotional or verbal abuse. So they define physical abuse as, did a parent or other adult in the household often or very often push, grab, slap, or throw something at you? And for emotional abuse, the question was, did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? So that's how they define that. If we look at ACEs in Nebraska, there have been national studies of this after this original study, mainly through large nationally representative surveys the CDC conducts, but there also has been information for Nebraska specifically. Unfortunately, the latest data I could find was from 2011, so it's a little bit old. But what we see here is that verbal or emotional abuse had the highest percentage of people marking that. So almost 30% said they had, of people who completed this survey, said that they had experienced that emotional verbal abuse. Similar numbers for substance abuse, and then around 20% of people said they had experienced divorce or separation. Again, this is adults reflecting on their childhood still. About 15% for mental illness and intimate partner violence, and probably, again, 15% for physical abuse, and then less than 10% for sexual abuse and incarcerated household members. In blue, I have that nearly 10% had 4 or more ACEs, so about 1 in 10 people fall in that high-risk category. Basically, the literature has shown that having 4 or more ACEs puts you at risk for a variety of negative health outcomes. I'll talk about what those are specifically in a minute. And at this point, people are probably adding up their own personal ACEs and seeing where they fall. Sadly, I'm one of these 4 or more people, so that finding always stands out to me like, oh, wait, this is problematic. So Douglas County more recently did a survey that looked at ACEs. So there's data from 2018 for Douglas County. It's a little more up to date. The questions were pretty similar in the Douglas County assessment. The categories were similar. Again, you don't see the neglect, though. That's just been dropped off for whatever reason. And I did notice that they measured physical abuse and emotional abuse a little differently. So for physical abuse, they asked, how often did a parent or adult in your home hit, beat, kick, or physically hurt you in any way? Do not include spanking. So they put that in there. And for emotional abuse, how often did a parent or adult in your home swear at you, insult you, or put you down? So that was similar to the original. And they added several more questions for sexual abuse. So I bring this up not to bore you with the details of how things are measured, but just to point out that when someone's giving their ACE count, when someone's talking about ACEs, if they've received a different survey, then they may have a different idea of what an ACE is, and their number may change if they took a different survey. So just throwing that out there. So Douglas County. It's similar to Nebraska as a whole. Again, there is a difference in terms of the Nebraska data was from 2011. This is from 2018. But basically, for Douglas County, almost 40% of people reported experiencing emotional abuse, 30% divorce and separation, and then about 25% for substance abuse. I won't go through them all, but the top 3 were very similar. But the prevalence is higher, as you can see, for Douglas County. And I did want to point out that for Douglas County, with this particular survey, they were able to split it up by different regions in Douglas County. And what they found was that those, for a lot of outcomes, not just ACEs, because this was a pretty comprehensive needs assessment, those residing in northeastern Douglas County had the highest ACEs, had some of the worst outcomes on a lot of different measures. So there's definitely disparities even in the community that we live in terms of what people are experiencing. And it's also important to note that whereas for the state, 10% had experienced 4 or more ACEs, for Douglas County, 15% had. Again, averaged across the different regions of Douglas County. So health outcomes and ACEs. Basically, adverse childhood experiences have been associated with a lot of different health outcomes. The one that's most relevant to us today is in purple, the unintended pregnancy, pregnancy complications, including preterm birth, and fetal death. But there are other ones here listed, of course: injury, traumatic brain injury, fractures and burns, mental health issues like depression, anxiety, suicide, and PTSD, infectious disease like HIV and STDs, chronic diseases of all sorts, including cancer and diabetes, alcohol and drug abuse and unsafe sex under that risky behaviors category, and then opportunities, education, occupation, and income differences. So pretty wide-ranging and serious outcomes, particularly, as I mentioned, for those who have the 4 or more ACEs. And this slide came from one of the first studies. It was basically the original study of ACEs. It's a little old, but newer studies have shown similar things. For this slide, I just picked out a couple of different outcomes that represent physical and mental health. And really what you see is with each additional ACE that a person has, their risk of having some of these poor health outcomes increases. And I will say that there's now literature on children, so not just the retrospective studies, but the prospective studies where they start when children are young and measure ACEs and measure development over time. And it's showing very similar things, that with one increase in ACE, your chance of having poor developmental outcomes also increases. So I won't go through all these, but the one that stands out the most to me in terms of the biggest difference between having 0 ACEs and having 4 ACEs or more is with depression in particular. So with 0 ACEs, about 10 or 15% of people in that category would be depressed. But with 4 or more, it's about 50%. So pretty stark differences there. So you might wonder, well, why is this? What's leading to all these poor health outcomes, including the maternal health outcomes, the premature birth? So our best available evidence right now kind of leads us to this pyramid. So there's this idea that some groups have historical trauma, slavery, things of that nature. There's also social conditions and local context. Those can play into whether someone has an adverse childhood experience or not. Once someone has an adverse childhood experience, it can lead to disruptive neurodevelopment. So there's a lot of literature in a related but kind of different field of toxic stress. Have people heard that term before? A couple people have. This idea that when children have serious, prolonged stress in childhood, particularly early childhood, and there isn't an adult there to buffer that stress, to reduce that stress, it can actually lead to changes in brain development, particularly the regions of the brain that are related to learning, are related to planning for the future, impulse control. So the next piece of the pyramid is the social, emotional, and cognitive impairment. The idea is then, because people may have difficulty cognitively, they may have difficulty managing their emotions, they may have difficulty with impulse control, that can lead, and because they may have mental health issues at that point, it could lead to the adoption of health risk behaviors like substance abuse or even, unhealthy eating, lack of physical activity, things of that nature, which can lead to disease, disability, and social problems, and early death. What I think is interesting, there's a pediatrician, Nadine Burke-Harris. She came to Omaha a couple of years ago. She does a lot of research on ACEs at this point in time, and she pointed out that this idea that trauma can live in the body. So while this is based on all the evidence we have in the field, this is how we think ACEs affect development and health outcomes. There could be other ways that don't necessarily include the adoption of health risk behavior, for example. So there's still a lot to learn. So that's ACEs, which it's, as we've learned, a large percentage of people in Nebraska and Douglas County could be experiencing, including pregnant women. There's also research on just general stress in pregnancy. So again, I couldn't find data from the last few years, but there was a study from 2011 that found that 70% of pregnant mothers in Nebraska reported experiencing a serious stressor. That's data collected through the Nebraska Department of Health and Human Services. And again, I thought people might get tripped up on, well, what is a serious stressor? Because we could all define that differently. So I've listed them here: job loss, homelessness, having to move. And you can see the rest on the list, but that's how they defined a serious stressor. So the most, I would say, pregnant women in this study were having at least one of those. 20% of women had 3 to 5 of those serious stressors, and 5% had 6 or more. So I bring this up because we know, independent of ACEs, stress in pregnancy is associated with preterm birth. There's still research being done. We're still trying to figure out exactly what is the mechanism, how do the stress hormones affect different pregnancy outcomes, but pretty consistently we see that finding. And so we know that ACEs independently affect preterm birth. We know that stress in pregnancy can predict preterm birth. What we don't really necessarily know is how does someone's ACE count, so a pregnant woman's ACE count, intersect with the stress she's having in her pregnancy to increase the risk of preterm birth in other ways. That's where there really isn't as much research. I think we can all probably agree, though, that there's definitely the potential for that. There's definitely the potential that someone could have had multiple ACEs in childhood and have significant stressors in their adult life during their pregnancy. So I think this is another area that we need to explore more in the research world. So that's really everything that might affect a mother who's pregnant and could give birth prematurely. But I have this quote, which is kind of dense, because I think it provides the link between pregnancy and then once the child is born. So the quote says, "The factors that create the biological risk in the mothers for prematurity may be the same factors that influence the inflammatory, hormonal, and neurochemical regulators that influence the mother's caregiving capacity once their premature infant is born." So I put this here just to say I think the most simple way to paraphrase that is women are having these stressors, they have the past traumas, that affects their pregnancy outcomes and the child's birth outcomes, but those issues don't disappear once the child's born. They're still a part of that woman's experience, and in fact we know that there are a lot of stressors just inherently with having a premature infant in the first place. So all of that can come together for kind of the perfect storm to set the stage for some of these adverse childhood experiences to happen. So again, moving kind of into prematurity, I'm not going to talk about all of the potential outcomes of prematurity because that's what really the focus is today, and there are people better qualified to go into all the ins and outs of that. But we do know that aside from how many ACEs a mother or the child themselves experience, just being born premature has a lot of risks. Of course, there are things that make those risks higher or lower, the moderating factors. Obviously, the weeks gestation and then the severity of health issues at birth play a big role. And I'll talk a little bit more about that later. But there could be, as you can imagine, the interaction of prematurity and ACEs. So we know, as I mentioned, that preterm birth predicts family stress and physical abuse. A lot of the literature that I found on stress of preterm birth, though, it seems like focuses most on the time in the hospital. There are a couple studies that focus on life after the hospital, but having had a preterm infant who was healthy by preterm standards, I mean, he's gone on to have none of the complications that are possible with a preemie. It was very stressful. It was unexpected that I went into premature labor. My child was in the hospital for 3 weeks. He wasn't home with us. When he got home, he didn't sleep well, he didn't eat well, had to eat through a tube, couldn't breastfeed properly and had problems with that. So even kind of in the best case scenario of a preemie birth, which is how I would classify mine ultimately, there's still a lot of stressors, even if you don't have other stressors or other like adverse experiences going on at that point in time. So there's also, I'm bringing up all these little pieces because we kind of have to piece together things to figure out how all of this ties together. But we also know that parental ACEs predict developmental delays for children. So there's that, I guess, unhappy piece of information out there. And that ACEs negatively impact cognitive development, social emotional skills, and health. So this is from research on children starting in childhood and looking at them over time. So we have like all these different pieces of the puzzle. What we don't really have that I could find, and if other people have encountered this, let me know, because I'd love to look at those articles. But I really was hard-pressed to find research that looked at ACEs specifically for premature infants, aside from general stress of families or the physical abuse piece of it. So again, just like with women's ACEs and current stress, it's pretty easy to see that there could be kind of a increased effect of having both a preterm birth and having ACEs in terms of developmental outcomes for the child. There just really isn't a lot of research on that right now. So in public health, we talk about the social determinants of health. It's jargony, so I'll break it down, what we mean by that. Basically, social determinants of health are things like economic stability, education, health and healthcare, neighborhood and built environment, and social and community context. So I bolded the ones that might be most important for preemies and really tie into this concept of adverse childhood experiences. So under economic stability, I had poverty and food security. We know that like all children, preemies need appropriate nutrition. For education, language and literacy, early childhood education, and early intervention. There's a lot of research on early intervention for preemies and how that can change outcomes and make them more positive. Access to health care. Obviously, preemies may have additional health needs. Access to healthy foods, and also just general environmental conditions. And then social cohesion, which is really, is there a community of support around a family and around a child? So I thought I'd just go through an example just to illustrate how this can play into overall development, but also in terms of adverse childhood experiences. So like I said, I feel like my case is really the best case scenario. Although my son was very premature, he was healthy by preemie standards when he was born. We also were not impoverished. We had food security. It was a planned pregnancy, so there's that. In terms of early intervention, we had access to that. He was born in Pennsylvania, but there was a system in place of early intervention. So when I had questions about his not reaching developmental milestones, for example, there was someone there to assess him, to offer feedback. I learned about that because I had access to health care. My pediatrician told me that we would be eligible for that and might want to pursue it. And we also had access to healthy foods, as I mentioned. He was formula fed, and you need special formula for preemies. It's quite expensive, but we were able to get that for him. We didn't live in a home that had lead or other toxins that also basically negatively affect brain development. And we had social support. So all of that together surely contributed to the fact that he is healthy today. But you can imagine someone, even again in the best case preemie scenario where there aren't major issues at birth, who didn't have food security, who was living in poverty, who didn't have regular access to health care because of transportation or just a lack of funds to cover it. They may not then hear about the early intervention that could help their child, and may have stresses around how their child was developing or unmet health needs. They may not have access to the funds to have the healthy foods, and they may not have the social cohesion to make sure that there was support. All of these things not only could affect kind of biological outcomes, but could affect stress in the family and tie in with things like abuse and people coping in unhealthy ways through alcohol and things of that nature. So I think this is how it all comes together through some of these social determinants of health. And then if you throw in even more severe health outcomes for a preemie, so maybe a preemie who was born extremely premature or just had additional health issues, all of this kind of intensifies those issues. So obviously intervening in those areas makes sense, but also just ensuring that families are able to utilize the resources that are available to them. I already mentioned early assessment and intervention, which is available also here in Nebraska. For children of a certain very, very low birth weight, they could be eligible for Social Security income. And I have insurance here too. As I mentioned, my son was born in Pennsylvania, and in Pennsylvania, he qualified for public health insurance, even though we also had private insurance. So that covered any additional medical costs that our private insurance didn't cover, which was great, because there can be a lot of costs, all the extra doctor's visits and assessments and things of that nature. I tried to figure out if that was also true in Nebraska, and I have to admit, it was really challenging to figure that out. So I feel like I know where to go because I researched these things. I've lived it, but it looked like you had to fill out a lot of questions, including all of your personal information to get an assessment of if you may or may not qualify. It was very challenging for me, and I throw that out there because, again, I've lived it. I have a PhD. I have pretty high health literacy. I know how to navigate social systems, I feel like, and get the things that I need for my family, but I still couldn't figure it out. So these are the types of challenges that families can face. As I mentioned, even with the early assessment and intervention, I learned about that through my doctor. I wouldn't have known otherwise. So if people don't have access to these other supports like medical care, they lose out on a lot of other potential benefits that they could have. And then the social determinants of health really focuses on context, on benefits that society could or could offer to individuals. But there really is a lot of research also for development in general, but particularly for premature infants, on focusing on ensuring that families are strong. This is the same thing that's recommended to prevent adverse childhood experiences. So in Nebraska, we have home visiting programs. That's where after birth, someone would go and provide, to some degree, parenting education support, answer questions, link an individual with resources. We also have parent training programs, although probably not as widespread as the home visiting programs, to, again, teach parents, and particularly parents of preemies, how to overcome some of the challenges or learn parenting skills to have a smoother experience with the child and to best promote, optimal developmental outcomes. And then intimate partner violence prevention. So without strong families, I would argue it's hard for preemies to do their best, so you might say, in terms of health outcomes, but particularly it's going to be challenging if there's other adverse childhood experiences involved. So that's what I had. I have my references. I wanted to point out a few. The first, and I'm happy to share this, or I don't know if it's shared widely anyway.
The PowerPoints will be uploaded to the same page that they registered.
Okay.
So you can access them there.
So if you'd like to know just more about adverse childhood experiences generally, this first reference, the Adverse Childhood Experiences webpage on the CDC's website, has a lot of information. Lots of research, summaries of research studies, links to full research studies on different topics, graphics if you want to use them in presentations, information about the original study, information, just anything you want to know about ACEs, it's there. I wanted to point out just one or two more. There's a very, very intense but informative chapter. It's the Masal Sabatka, lots of authors on that one from 2018. life course health development outcomes after prematurity, developing a community clinical and translational research agenda to optimize health, behavior, and functioning. That's in an open book, so you can access that chapter, and actually the whole book, Life Course Health Development, which I use in one of my courses, you can access that online for free. And it has just a lot of information about developmental outcomes for preemies and what we can do in communities to basically improve outcomes. And then the last one that I wanted to point out was the Professional Research Consultants 2018. That's that community needs assessment that I mentioned. And you can look at all the results of different health outcomes across Douglas County if you're interested. And I guess my last thoughts would just be, as I mentioned, I feel like I have really the best case scenario in my son's outcomes. And the reason that I wanted to give this talk today and come here, even though I focus more on adolescents, I want everybody to have those outcomes. I want all the preemies to have the positive outcomes that he has. And one way that we can get there is by, addressing adverse childhood experiences and making sure that preemies and all children, when possible, are not having those experiences or getting the right interventions to address those experiences. So that's it. If you have any questions, I don't know. I think we might have a few minutes. And feel free to reach out to me afterwards if you have questions as well. So I guess I'll open it up. Yeah.
What are your thoughts about incorporating ACEs into eligibility criteria for early intervention services? So factoring in ACEs as part of the determination process.
I think that's a great idea because as much as that we still don't know, we do know enough to say that ACEs could lead to disability ultimately, especially for those already at risk, for preemies in particular, who are already at risk of disability. This could just intensify. So I think that's a great idea. Generally what I hear, because I work with different healthcare providers on the Adolescent Health Project, which was mentioned in the beginning, and they have talked about screening for ACEs among their clients. What I hear as challenges is not having enough staff to actually respond to the screener. So you screen people for ACEs, maybe they have that high score, and then what do? Is there a 2-month wait to get them into mental health services? That's what I hear as the challenge. It sounds like, I'm not sure if that would be a challenge in this context too, but I see a lot of community interest in this topic, but how to implement something that will improve people's experiences seems to be a little more challenging just because of lack of providers to address some of these issues.
I know sometimes within early intervention, they're factoring it in if it's included in a report of some sort that comes in with the child.
Yeah.
So they're not using it to determine eligibility or to provide educational verification, but they are factoring it in, especially in children that maybe wouldn't otherwise be eligible.
Mm-hmm.
So I just wanted to hear that's a newer thing. So
Yeah.
I agree with you.
Well, good. I'm glad. Any other questions or things that should be clarified?
Tell me more about the parent training program and how someone would access that.
Yeah, so I know that Child Savings Institute sometimes offers parent trainings. And also I've seen them advertised through Boys Town. My child goes to Children's. I haven't personally seen as many through Children's, but I think sometimes they do offer them. So I would look at those agencies' websites, but there are several, whether or not they're being offered in Omaha all the time, I can't tell you, to be honest, but there are a lot of evidence-based parenting interventions that teach parents how to work with their child's temperament, how to address behavioral challenges, things of that nature. So they do exist and they're out there. I will say when I see ads for parent trainings in Omaha, it's not consistent, and that might be a barrier. But I know I've seen them through Boys Town and Child Savings Institute. Any other questions? All right. Well, thank you.